Good morning, everyone. Are you hearing me?
Good morning, Doc. Yes.
Right. So this morning we're going to be looking at the slipped upper femoral epiphysis. Now, one of the things that you have to know, and you'll be asked at some point um, in your medical career, is that you have to know the causes of hip pain in various age groups, whether it's be a newborn, um, whether it be a child, whether it be an adolescent, and whether it be an adult. And so one of the things we're going to be looking at today is one of the common causes of pain in the hip of an adolescent. And so today we're going to be looking at the slip upper femoral epiphysis. Now, as the slide shows, a slipped upper femoral epiphysis is really a disorder of the proximal physis of the femur in adolescents, resulting in movement of the femoral head relative to the neck. The femoral head moves posteriorly and inferiorly relative to the neck. Now, the truth is, because the femoral head is confined within the acetabulum, it really can't move, and it's really the neck that moves to the relative to the head. But because we have become accustomed over the years to talking about movement of the head relative to the neck, we continue to use that in speaking about this disorder. Now, one of the things that we have to recognize is that this is a relatively common disorder. With an incidence of 2 per 100,000 in the United States. Blacks are affected more often than whites. Males are affected more often than females. And the interesting thing is that is in boys, the left side is affected twice as often, while in girls, there's an equal distribution between the left and the right side. Now, as you know, girls mature and go through puberty earlier than boys. And so this disorder affects girls in the age group 10 to 12, while it will affect boys in the age group 12 to 14. Now, what are some of the causes of slipped upper femoral epiphysis? One of the causes is trauma. So, for example, the adolescent may be playing football and he's tackled, or after the game, he just starts to complain of right hip or thigh pain and is unable to continue playing and has to limp off of the field. So one of the causes is trauma. Then there are genetic factors like Klinefelter's disease, which you know is XXY, Down syndrome, which is trisomy 21, and Marfan syndrome, which you know is a disorder in collagen. And the typical feature in Marfan's is that the patients are tall with long limbs. When it comes to Klinefelter's and Downs, we're not quite sure what is the disorder in these syndromes that cause patients to be predisposed to slip upper femoral epiphysis, but we know that there's an increased incidence of the slip upper femoral epiphysis in these disorders. Then we know that there's some mechanical factors that lend themselves to the slip upper femoral epiphysis. Patients with a slip upper femoral epiphysis have a more vertical physis than normal individuals. The acetabulum is also deeper, leading to increased shear stress across the physis. And the normal hip is anteverted, but in patients with a slip upper femoral epiphysis, we may notice that there is reduced anteversion of the hip. There's some endocrine disorders like hypothyroidism, hyperthyroidism, acromegaly, and cryptorchidism, which you know is the undescended testes, that can lend itself to a slipped upper femoral epiphysis. We know metabolic disorders like rickets can also cause it, and renal osteodystrophy and obesity. So these are some of the etiological factors associated with the slipped upper femoral epiphysis. Now, the question we have to ask ourselves is, how does the patient with a slipped upper femoral epiphysis present? And one of the things I want you guys to remember, if you forget anything else I've said today, is that these patients can present with pain in the thigh or pain in the knee. And so many times adolescents present to their general practitioner with pain in the knee and a limp, and the general practitioner spends a lot of time getting x-rays of the knee and MRIs of the knee and CT scan of the knee, and forgetting that slipped upper femoral epiphysis can present with pain in the knee or the thigh. So I want you to remember that. The patient with a slipped upper femoral epiphysis will also have an antalgic gait. And by antalgic gait, mean they're walking with a limp, and the stance phase on the affected side is reduced. The limb will be also externally rotated. When you're examining the patient, you'll notice that they have decreased internal rotation of the hip, and whenever you try to flex the hip, you'll find that the hip naturally externally rotates. Some of these patients will also have a limb length discrepancy. So this is a clinical presentation of the patient with the slipped upper femoral epiphysis. Now, just give me a minute here. Now, in orthopedics, we always attempt to classify disorders because our classification helps us in the management of the problems. And so in the slipped upper femoral epiphysis, we classify it by pre-slip. In a pre-slip, patient has clinical features, but there's just on a plain radiograph, there's just widening of the physis. Then there's what we call an acute slip, where the patient has had symptoms for less than 3 weeks. Then there's a chronic slip, in which the patient would have had symptoms for greater than 3 weeks. And in these patients, there's usually some radiological features that are consistent with a chronic slip. So I will show you what those radiological features are in a little while. And then, of course, we have the acute on chronic slip. So that's our classification that we use in patients with a slipped upper femoral epiphysis. Now, once you've done your examination, the next thing you want to do is your investigations. And in getting your investigations, you want to get plain radiographs of both hips. First, an AP, and then what we call a frog's lateral. And I'm going to be showing you some important lines on the plain radiograph, one of which is Klein's lines, which you're going to be looking for, because normally in a normal radiograph, Klein's line should cut off a bit of the femoral head, while in a slipped upper femoral epiphysis, it doesn't. In a slipped upper femoral epiphysis, you'll also notice that there's a decreased height of the epiphysis, and there's also what we call a metaphyseal Blanch sign. Now, we also have a classification in terms of looking at the severity of the slip. So when the femoral head slips less than a third of the diameter of the neck of the femur, that is a grade 1 slip. If it slips more than a third but less than a half, it is a grade 2. And if it slips more than a half of the diameter of the neck, then it's a grade 3. So this classification shows an increasing severity of the slip. Now, here we have a radiograph which shows an AP and what's termed a frog's lateral. Now, one of the things that you will notice is that on a frog's lateral, you can see that the femoral head is slipping off of the neck. I want you to in your mind, visualize that you've gone to Tutti Frutti and you have bought a ice cream and you put it on your ice cream cone and you've licked your ice cream and you've licked it too hard and it's about to slip off the cone. And so you can see where this femoral head is moving posteriorly and inferiorly on the femoral neck. Can everybody appreciate that as I pointed out with the blue arrow? Okay, right. So that is what a slipped upper femoral epiphysis looks like. Now, other thing that we said before is we can classify it clinically in terms of a pre-slip. And we said on a pre-slip, the only thing you're going to see on the radiograph is widening of the physis. And here you can appreciate the green arrows showing you that the physis is widened. That's what we call a pre-slip. Now, a mild slip, as we said, is where the femoral head has moved less than a third of the diameter of the neck of the femur. A moderate slip, as we had pointed out earlier, is one where the femoral head moves more than a third, but less than a half of the diameter of the femoral neck. And a severe slip is one where the femoral head has moved more than a half of the diameter of the femoral neck. Now, Dr. Obasi Etienne.
Yes, Doc. Good morning.
Good morning. Now, can you look at this X-ray and point out to me which side has the abnormality?
That would be the left side, Doc.
The left side. Now, why do you say the left side is abnormal?
I can see that the femoral head has slipped off of the neck of the femur.
Can you point that out to me with the pointer?
Sure. Right here.
Right, so the femoral head is obviously slipping off the femoral neck. Now, earlier I pointed out to you that there's what is known as Klein's line. And I'm going to be drawing that for you. So Klein's line is a line that runs along the superior border of the neck of the femur. So if you were to draw Klein's line here on the left side,
To be honest,
it doesn't touch the femoral head whatsoever. While if you do it on the other side, which is normal, you can see that it cuts some of the femoral head. Is that clear?
yes, Doc.
Right. So that's what we call Klein's line. Now, another important line that you will learn about in orthopedics is Shenton's line. And in Shenton's line, that's a line that runs along the inferior border of the neck of the femur, along the inferior border of the superior ramus of the pubis. And you can see plainly that that line really shouldn't touch the femoral head. But whenever you have a SUFE, as is the case here, you can see that the femoral head has cut into the Shenton's line. Now, the other thing that we spoke about earlier was the metaphyseal blanch sign. And the metaphyseal blanch sign is just because there is overlap of the head of the femur on the neck. So I'm just going to circle that area for you. All right? So does everybody appreciate that? So the radiological features we're looking at that clue us in, as your colleague Dr. Entienne pointed out, you can see the femoral head is slipping relative to the neck. we can see that Klein's line no longer cuts into the femoral head. Yes, the metaphyseal Blanchstein is an area which is slightly hyperdense, and that's just because the femoral head is overlapping the femoral neck. And we can see Shenton's line, which normally doesn't cut into the femoral head, is cutting into the femoral head. Now, one of the other things that we mentioned earlier was that there are certain radiological features that would suggest to you that the patient has a chronic slip. And here on the left side, we can see the patient has a chronic slip. And so one of the characteristic features of a patient with a chronic slip is that you get rounding of the superior portion of the femoral neck. Here you can see it's pointed out as the anterior bump, rounding of the superior portion of the femoral neck, and then inferiorly you have new bone formation, right? As the femoral neck attempts to remodel to accommodate the new position of the femoral head relative to the neck. So once you see these signs of remodeling, you know that you're dealing with a chronic slip. An acute slip, on the other hand, will show no evidence of remodeling. Now, the important thing that you must also remember, if you forget everything else, as I said, one thing you have to remember is that the patient with a slip upper femoral epiphysis will present with pain to the knee or the thigh. Please don't forget that. Now, once this patient presents to you and you've examined them, you've investigated them, and you've made the diagnosis of a slipped upper femoral epiphysis, this patient cannot be allowed home. This patient has to be admitted and placed on traction. And you'll be keeping this patient on traction until the pain resolves. Why do we put the patient on traction? Because if we don't put the patient on traction, they're going to attempt to weight bear, and this is going to exacerbate the condition. All right, so a pre-slip can go to a grade 1, a grade 1 can get to a grade 2, a grade 2 can go to a grade 3, and with increasing severity, the risk of complications increase. And we'll be looking at the complications in a little while. And so we place the patient on traction. Now, one of the interesting things is that by placing the patient on traction, some of the patients actually experience a decrease in the severity of the slip. What do I mean by that? A patient who has a grade 3 slip, when we do some x-rays a week or two after, when the pain settles down, it has gone to a grade 2. A grade 2 has gone to a grade 1. So one of the things we've noticed is that when we put our patients on traction, that not only does it prevent the slip getting worse, but it can actually cause a decrease in the grade of the slipped upper femoral epiphysis. Once the pain settles down and the patient is having no more pain, then the next thing we do is what we call an operation where we pin the femoral head in situ, which means that we put a single screw going from the lateral cortex of the femur up into the neck and up into the head. And this will hold the femoral head that it doesn't slip any further. Because if it slips any further, it will slip right off and undergo that dreaded complication of the slipped upper femoral epiphysis called avascular necrosis. Now we're going to be looking at the complications of the slip upper femoral epiphysis. The complications, the most common and the most dreaded, is avascular necrosis of the femoral head. In other words, the femoral head dies and disappears, and that leaves the patient with a painful hip. All right? And so because we fear this complication, we always admit our patients and intervene once the pain settles down. The other complication we worry about is chondrolysis. Now, chondrolysis is inflammation of the cartilage, which results in a stiff and painful joint. So not only do you have inflammation of the cartilage, but you have loss of the cartilage, and the patient can end up with a stiff, painful joint. The other complication of a slipped upper femoral epiphysis is that over time, as the patient ages, because of the change in the biomechanics about the hip joint, the patient can end up with osteoarthritis of the hip joint. I also want to point out to you that these patients with a slipped upper femoral epiphysis, we follow them until they reach skeletal maturity. And that is because once you've had a slip on the other one side, you're at increased risk of a slip on the other side. Truth be told, patients with endocrine disorders are at a high risk of a slip on the contralateral side. And so for those patients, we usually prophylactically pin the contralateral side. And so this morning, we have looked at the slipped upper femoral epiphysis. We have defined it. We have looked at some of the predisposing factors and the etiology, at the clinical presentation and investigations. We've looked at the treatment, and we have looked at some of the complications. So Dr. Ashley Scott, let us see if I've bored you guys to death or if you've learned anything. Dr. Ashley Scott?
Morning, Doc.
Good morning. What do you understand by the term slipped upper femoral epiphysis?
Pardon, Doc. What did you say? What did I understand by the
How
term?
would you define a slipped upper femoral epiphysis?
I guess it's the displacement of the femoral epiphysis from the metaphysis.
All right. So it's a disorder of the hips in adolescence where the femoral head moves relative to the femoral neck. Okay?
Yes, Doc.
Right. Now, Dr. Brittany Bryan,
Yes, Doc.
who gets this slipped upper femoral epiphysis?
Usually adolescent children, so in females it would be from age 10 to 12, and in boys it would be 12 to 14.
Very good, doctor. Right. Is it more common in boys or more common in girls?
In boys,
In boys, very good. Dr. Daniel Drakes?
Yes, Doc, I'm here.
Yeah, good morning. Dr. Drakes, what causes the slip upper femoral epiphysis?
Well, it can be caused by trauma, and that is normally the most frequent cause of these slipped upper femoral epiphysis, but it could
Yes.
also be due to other causes. Um, I think obesity could be a risk factor because of the extra weight on the loading on the area as well.
Yes.
And yeah.
That's it, trauma and obesity?
It's associated with endocrine disorders. So you have your hypothyroidism, which is common in patients who have these pathologies. It could be in Down syndrome, and I can't remember the others.
Okay, all right. All right, so remember we spoke about Klinefelters and Marfan's, all right? And in terms of our endocrine disorders, we spoke about hyperthyroidism, hypothyroidism, and cryptorchidism, all right? Now, Dr. Akeem Hay. Dr. Akeem Hay.
Morning, Doc.
Yeah, morning. Dr. Hay, these patients, how do they present clinically? A patient with a slipped upper femoral epiphysis, how do they present clinically? What are the clinical features?
They can present with pain whether in the hip, the thigh, or the knee, You can present with a limp.
Yes.
Present.
When you put them through the range of motion, what do you notice?
And there is reduced range of motion when it's painful.
Right? Reduced range of motion in which direction?
I'm not too sure.
All right, so they'll have a reduced range of motion in internal rotation and in also abduction, okay? Now, Dr. Graham, Hannah Lee Graham? Dr. Graham?
Yes, Doc. Good morning.
Good morning. Now, Dr. Graham, what investigations do you want to get on a patient who you presume has a slipped upper femoral epiphysis?
Well, you don't want to do a plain radiograph.
Right? Just an AP, what you want to get? What films? Just an AP film? Dr. Graham?
Hello, Doc. Sorry, my mic was off. An AP and a Frog's lateral.
Right, so an AP and a Frog's lateral. And what features are you looking for that would suggest that the patient has a slipped upper femoral epiphysis?
Well, you're looking for Klein lines. You're looking for a decreased height of the epiphysis.
Yes.
And the metaphyseal Blanch sign.
Very good, very good. All right. Dr. Jessica Gay?
Hi.
Right, so morning. Question, so you've made your diagnosis of your slipped upper femoral epiphysis. What are you going to do for this patient? Are you going to send them home and give them an appointment to come back? How are you going to treat this patient?
So basically, you have to admit them and apply traction to the limb until the pain resolves. And yes, that's all I remember from that.
Right. So when you admitted them and you place them on traction and the pain has resolved, what you going to do next?
I will. I guess repeat the X-ray and then maybe see if surgery is an option. No, not surgery. I
So
can't.
let me ask a question, Dr. Gay. When you go to Tutti Frutti and you buy an ice cream on your ice cream cone and you're licking it and it's about to fall out of the cone, what do?
You try to put the ice cream back on the cone.
Right, because you don't want it to fall off. So likewise, when we have patients with slipped upper femoral epiphysis, we don't want the ice cream to fall out of the ice cream cone. And so what we do is surgery, in which we put a screw up in the femoral neck into the femoral head so that the femoral head can't slip off the femoral neck. What we call percutaneous pinning.
Right.
All right?
Okay.
Now, so that's the surgery that we would do. And Dr. Ryan Pedro?
Good morning, Doc.
Good morning. Dr. Pedro, what is the complication we worry about most with the slipped upper femoral epiphysis?
Avascular necrosis of the femoral head.
And what is avascular necrosis? What's that?
It would be basically death of the head of the femur.
That's correct. Death of the head of the femur. All right. So it seems like you guys have benefited somewhat from the presentation this morning, where we have looked at the slipped upper femoral epiphysis. We have defined it. We've looked at the incidence. We've looked at the etiology. We've looked at the clinical presentation. We've looked at the investigations. We've looked at the treatment, and we have looked at the complications. And so the take-home message is: one, patients with a slip upper femoral epiphysis can present with pain in the thigh and knee. So if you see an adolescent limping into your office, complaining of pain in the thigh or knee, the first thing that should come to your head is this a slipped upper femoral epiphysis? The second thing that you have to remember is that these patients cannot be allowed home. They have to be admitted right away and placed on traction. And the treatment of a slipped upper femoral epiphysis is percutaneous pinning inside tube. Any questions? Yes, Dr. Hay.
Good morning again, Doc. Would the percutaneous pinning through the physis affect growth?
All right, so sometimes what happens is that you can get, and it's actually what you want to achieve, is fusion of the femoral head and the femoral neck. And truth be told, there is decreased growth in the proximal femur because of that. But the good thing is that most of your growth takes place at your knee, distal femur and proximal tibial. So although you will lose some limb length, it is not as much as if you had fused the physis of the distal femur. But children who have a SUFE will end up with a limb length discrepancy.
All right, thank you, Doc.
Any other questions? All right, if there are no other questions, we're going to be bringing the session to an end. And I want to thank everyone